thank you for inviting me. Today I will present a quick description, only 10 minutes, on the 2022 Ebola Sudan outbreak in Uganda. And we'll start with a bit of history first. Oh yeah, it's me. So Uganda's first and largest Ebola virus struck Gulu in 2000, and it was the Sudan strain discovered in 1976. It affected 425 people and had a CFR of 53%. Then the next outbreak was in 2007, but it was a new strain, Budibugyo, infected 131 people with a 32% CFR. And these were followed by two smaller Sudan virus outbreaks in 2011 and 2012, two in Luwero and one in Kibale. And finally, there were 4 cases of Ebola Zaire that were imported from the DRC in 2019, but with no secondary cases. So today we'll discuss the Mubende 2022 outbreak with a focus on 3 stories of operational importance. The first one on the mobility of the population, the second one is about a super spreading event, and finally we'll talk about the demographic dynamics of this outbreak. So first, let's look at the outbreak in time and space. So here we have the epicurve on the bottom, which is and a map of cases in the background. And the outbreak began actually in Mubende in August 2022. And it was linked to a rural clinic in Madudu, Mubende district, where several children diagnosed as malaria were subsequently classified as a probable Sudan virus death. And we will circle back to these kids at the end of the talk. And then this outbreak was actually detected on September 2022, on 19th of September, when a farmer was confirmed to be Ebola Sudan positive by PCR, and he later died at the hospital, Mubende Regional Hospital, and several clusters of cases developed in the hospital and broader districts. So this facility became the natural site for the first Ebola treatment unit, or ETU, and the decision was also made to set up another ETU in Entebbe, near the capital. And of note, you can see on the epicurve that already 36 Sudan virus cases were either sick or dead at the time of the confirmation. So neighboring districts were rapidly affected, particularly Kegegwa and Kasanda, 2 neighboring districts, and the second of which, Kasanda, was contributed heavily to a second peak of cases. Medical teams specialized in highly infectious diseases were rapidly deployed, and we can see the resulting effect on the survival rate overlaid on the epicurve, which is beginning to increase. And as the outbreak passed its first peaks, Mubende and Kasanda enforced full lockdown to limit the spread. This phase also saw the setup of multiple isolation units, small isolation units that were deployed by MSF that we distinguish from large traditional ETUs. But importantly, mid-October is also when we see the outbreak spread to the capital, when an infected healthcare worker and a patient have traveled to Wakiso and Kampala districts respectively, both generating secondary cases. And then 2 of these secondary cases in Kampala also traveled to other districts, one to Masaka to the south and the other one to Jinja, you see on the map. And again, MSF has rapidly deployed small isolation units in these 2 districts. So the outbreak officially ended on January 11th, 2023, with a total of 142 confirmed cases and 22 probable cases. And the CFR was 39% considering the confirmed cases and 47% overall. And geographically, it has been the most widespread ever outbreak in Uganda, affecting 9 districts. So as we just saw, this outbreak was characterized by substantial mobility of cases, with many districts affected in a very short period of time. To keep pace, MSF has implemented small isolation units, which could be established much faster than traditional ETUs. And this was achieved, this was possible thanks to a successful collaboration between MSF, but also the MOH, WHO, ALIMA, and the CDC. But while this collaboration was a success, it is also important to note that rapid isolation units only are a partial response to the problem of mobility during epidemics of Ebola, which is ultimately driven by fear and misunderstanding. And therefore, we think it's important for us that we continue to look for improved methods of engaging and communicating with the local population going forward, and particularly as with the ongoing expansion of the road network, mobility will only become easier in future epidemics. So let's shift now from our macro view to a particular story, a super spreading event in Chikandwa, Kasanda district. And here you can see all the transmission events that were documented by the Ministry of Health. Some are still missing, but we want to focus on a specific one, which is this one. And at the center of this cluster, this man was a very popular person, and he used to make food for his friends, and he did that while he was sick, so of course all these were highly exposed. After he died, he precipitated 33 secondary cases, which is a huge number, and the CFR among these cases was actually 45, which is about the average of the outbreak. But what is particularly striking is that only 7 tertiary cases were generated from these 33. And this is very low. And the successful containment of this super spreading event is likely attributable to the actions of the clinician in charge of the health center, who rapidly identified the sick contacts the contacts of this man and provided them with clear explanation about the disease. And then he rapidly isolated them in a specific ward here that we see with the blue roof facing the health center. And finally referred them, and he also implemented infection control measures to protect his other patients that were not linked with that cluster. So what we see here is, oops, sorry, back. What we see here is that, of course, communication and minimal IPC and also availability of isolation room is making a difference, right, to stop transmission and severity of cases. But it also underlines the importance of regular healthcare facilities in the overall outbreak response, as their staff have pre-existing trust relationship with the local community. And so this works when staff are knowledgeable about VHF, and this underscores the value of trainings not only for specialized staff, but also for all clinicians. For our final story, let's talk about demography. And here you can see the breakdown of female and male cases by age and final status. During this outbreak, males were significantly more infected than females, and this difference, this imbalance is actually likely due to the super spreading event we just mentioned, which had more than 80% of males. We also see that most cases lie in the young adult age range, and finally we also note a substantial number of cases in children under 10. We also observe a different CFR among male patients, lower CFR among male patients, but this difference that we see is not significant. But the U-shaped curve is a more classical finding with more survival among young adults, right? So what we want to point here, what is particularly interesting, is the high proportion of children at the beginning of this outbreak. And these are the children we mentioned at the beginning of the talk that were suspected and diagnosed with malaria, and later on reclassified as Sudan virus cases. So for us, this suggests two things. Clearly, we need to improve our capacity to detect viral hemorrhagic fevers like Ebola, and one approach would be to incorporate rapid diagnostic testing within epidemiological surveillance. And second, we know it's easy to confuse viral hemorrhagic fevers with malaria, and that most countries affected by VHF also know high and perennial malaria endemicity, and therefore we think that malaria chemoprophylaxis during outbreak would reduce, on one hand, the load of patients suspected of EVD, because less malaria patients, and also the risk of transmission within the regular health system. Conclusions. So in conclusion, the 2022 Sudan virus outbreak was rapidly controlled despite quite unprecedented geographic spread. So we have observed both successful approaches and also ongoing challenges which can inform our preparedness effort for the future epidemics. So we think it's important to continue to prepare for increasingly mobile populations. And I think there is a great amount of work which is done by MSF Logistics on this. We should adapt messaging to the specific populations. We should also support the preparedness of regular healthcare facilities, as we see it has made a big difference in some cases. We should also consider mass administration of malaria chemoprophylaxis during VHF outbreaks, and also integrate rapid diagnostic testing in epidemiological surveillance. And I did not mention this at all, but of course, vaccines and treatment will be very important also to reach the control of outbreaks. I would like to thank the following people, all healthcare workers and all people listed, and thank you for your attention.